All right, I want to thank everyone for joining the session. My name is Vinay Mehta. I'm the moderator of the Database SIG poster walk session. First, I want to thank my co-moderator, Xiaofeng Zhao, and who's also currently the chair of the Database SIG. I also want to thank the presenters that we have today, and we really look forward to all the great presentations that we're going to hear. And just before we get started, just a quick plug, we have our annual Database SIG meeting scheduled for September 17th from 10 to 11 o'clock Eastern time. So Xiaofeng and I encourage all of you to attend that meeting, learn about all the exciting things that have been going on with the SIG over the past year, and also what our future plans are for the upcoming year as well. So just a few housekeeping notes. All attendees are going to be muted, so all questions should be logged in through the I think it's the Q&A window at the bottom of your screen. All sessions are going to be recorded and available after the session. And as I mentioned, each of the presenters will have 3 minutes to give their talk, and then there will be 2 minutes immediately after that for Q&A. So without further ado, we can get started with our first presentation. So the first presenter is Marieke Asendorf from Leibniz Institute for Prevention Research and Epidemiology. And she'll be presenting information on the socioeconomic status in the German pharmacoepidemiological research database, completeness and proof of concept analysis. And give me 1 second. I'm going to pull that presentation up right now. Okay, Marieke, it's all yours. You can tell me when to scroll down.
Yeah, perfect. Thank you very much for the kind introduction, and hello from my side as well. I'm really glad to give you a short overview of our study today. So the socioeconomic status, short SES, is of great importance in epidemiologic research, in particular as a confounder. However, the SES is often not available in healthcare databases, which are an important data source in pharmacoepidemiology. However, healthcare databases might actually contain information that can be used to estimate the SES. For example, the German Pharmacoepidemiological Research Database, short JEPED, which is a claims database, contains information of the district of residence and on the educational attainment. The aim of our study was therefore threefold. Oh, I think the sharing stopped, at least for me it did.
I apologize, yeah.
No problem. Yeah, perfect. Thank you very much. So yeah, the aim of our study was threefold. So the first thing was to estimate the SES in JEPED based on A, individual level information, and B, district of residence. Second, we determined the completeness of individual level information on the SES. And third, we wanted to assess the plausibility of the estimated SES by investigating whether the known association between a low SES and high obesity prevalence can be reproduced in JEPED. To estimate the individual level SES, we used any information that was available during the observation period on the highest level of school education of each person. If no information was available, then we used information of any linked family member. The aggregate level SES was estimated using information on the district of residence, which was linked to the German Index of Socioeconomic Deprivation. That's a district level measure of the SES. Our results, so maybe now you can scroll down, please. Our results show that an individual level SES could be assigned to 85 to 93% of the insurance under the age of 60, and then for 67% of the insurance aged 60 to 69. The proportion was lower for older persons. We found actually a plausible association between a low SES and a high prevalence of obesity for both estimates of the SES. This association was, however, stronger when using the individual level SES. You can see that in figure 1 and in figure 2. So in conclusion, our findings indicate suitability of SES variables for future Jeopard-based analysis. That particularly holds true for the individual level estimate of the SES. Thank you very much for the attention, and I'm looking forward to any kind of questions that you might have.
Thank you, Marieke. I had one question actually.
Yeah.
Just looking at table 1, there's a big sort of drop off when you go from the 60 to 69 to the 70 to 79 age group, and I'm just wondering if there's an easy explanation for that.
Yeah, there actually is. It's because the information on the occupation, we get that from the employee. And we have a look back period, but unfortunately for those who have already been retired for quite a long time, we usually don't reach that point in time where they still were employed. So we don't have this information from the employee, unfortunately, for this age group.
Thank you.
I also have one question. Is there any reason you didn't consider the race in this analysis?
Sorry, I couldn't really understand that question. Could you?
Is there any reason that you haven't include the race or ethnicity as a variable in this analysis? Or have you? I'm seeing just the age, gender, education, and I'm wondering if those other socioeconomic variables, such as race and ethnicity, should be considered.
Yeah, thank you for that question as well. The reason why we did not include that is because we wanted to give a classical socioeconomic status that then can be we can add that to other information that we have that is not ethnicity in our database, but we do have information on the nationality. Well, we do have information, but it's not perfect, obviously. But the reason is that we wanted to give a clear socioeconomic status. So we wanted to have these classical 3, actually we would have loved to have these 3 dimensions of it, but we're lacking information on the income. So we were only able to use the education on the individual level, and then on the aggregated level with this deprivation index, we used all the 3 classical indicators.
Xiaofeng, do we have any other questions from the chat window?
No, we don't.
Okay. It seems like there are no more questions, so thank you, Marieke, for a great presentation.
Thank you very much.
Okay, I'm going to pull up the next presentation. Okay. Give me 1 second. I just got to pull it up on my screen. Can everyone see this presentation, Maritzel?
Yes.
Yes.
Yeah, but it should be smaller, right? Because
Yeah, I'm sorry, give me 1 second. It's okay, hold on 1 second. I'm gonna have to, my screen is a little bit messed up right now. I apologize, everyone.
Vinay, this is Shannon. Would you like me to see if I can share my screen?
I think I have it. Give me 1 second. I'm just trying to here we go. All right. Is this still small for everybody or is this better? I'm on the disclosures right now.
It's better now.
Okay, okay,
Great.
apologies. All right, sorry about that. So our next presenter is Meritxell Sabid from the Danish Multiple Sclerosis Center and Registry, Copenhagen University Hospital. And she will be presenting novel use of harmonized data quality indicators in long-term safety studies using multiple sclerosis registries, approach in Clarion study.
Okay, thanks for the opportunity to do this presentation. And just a small clarification, I'm not from the Danish MS registry, I'm from Merck KGaA. So, and I'm presenting this poster on behalf of the co-authors that are coordinators of MS registries, IQVIA team members, and Merck colleagues. So, in terms of the introduction, when it comes to patient registries, including those in the setting of MS, one of the recommendations of the EMA Patients Initiative is to use harmonized standard indicators and solutions across registries to help ensure consistent data quality. The Clarion is a multi-country comparative long-term cohort safety study based on primary data collection and mainly on secondary data collection that involves 9 MS registries. And in this poster, we describe an evaluation of Clarion data quality over time through the use of predefined data quality indicators in participating MS registries. Next, please. For methods, there were 28 predefined data quality indicators to assess 4 aspects of data quality: representativeness, consistency, accuracy, and completeness. And at each data cutoff, from 2021 back to 2019, data quality indicators were summarized by the respective registry and overall. Next. Regarding results, we report data from 2,393 patients from 7 participating registries up to May 2021. And let us consider the 4 aspects of data quality in terms of what we found. For representativeness, the data appear representative of the MS population. So we have a majority of patients that are female, and average age at MS onset is in the early 30s. Next, please. For consistency, as you can see in this figure, the proportion of patients with no visits during the first year before each data cutoff changed little overall. And this needs to be pointed out that it includes the time of the first wave of COVID. Nevertheless, some changes were observed for individual MS registries, and this is, for example, the Swedish one that improved over time. Next. In the accuracy component, we assessed discrepant dates, and the conclusion was that indicators were of acceptable quality with better values in the last data cutoff than in previous year, which signaled an improvement in terms of accuracy. And in terms of completeness, that we assess completely missing values, the indicators showed also improvement over time, and in particular, we assess reasons for discontinuations and discrepant dates. Let's move to conclusions next. To conclude, our analysis shows how data quality indicators has helped the team to identify potential data inconsistencies and methodological differences across participating registries over time, including outcome definitions as treatment discontinuation. And this has helped to identify issues before, at an early stage before statistical analysis. So the introduction and the application of these data quality indications in Clarion has improved data quality over time, in particular completeness and accuracy. Thank you very much, and I'm happy to take questions.
No question on chat yet for me.
Okay, so there is one question in the chat window.
Oh, okay, no, yeah, not just
Yeah.
one, yeah.
So the question is, are the registries in the same format? If so, they were created as such from the beginning or harmonized later on?
So the registries were already existing, and we are extracting data that has been collecting for other purposes, not for the purpose of the study. That's why each registry has heterogeneity and has their own data structure. In some, as the indication, it's multiple sclerosis. This helps in a way because they all collect the same, let's say, effectiveness outcomes or safety outcomes, but still you have to deal with the heterogeneity, and this is a challenge for this type of studies. So the harmonization and the mapping and harmonization was done specifically for the study.
Thank you. Xiaofeng, are you seeing any other questions in the Q&A window?
No.
Okay. Okay, thank you, Meritxell.
Thank you.
I think that's it. No additional questions. Okay. All right, let me pull up the next presentation. Okay, our next presenter is Deborah Layton, who will present performance of different definitions for COVID-19 infection across European databases.
I'm terribly sorry, the wrong poster has been posted here.
I'm sorry?
The wrong poster has been uploaded. We sent a replacement poster.
Oh.
This has not been
I just downloaded it today.
uploaded, and I had
okay, do you want to go ahead and take control then and share your screen and present the...
I will try and pull it up very quickly. Let me see if I can do that. Sorry, so you'll have to...
Sorry, I think I downloaded it earlier today, but I haven't downloaded it in the past.
Right, okay. All right, I'll try and make sure this, so it's just going to be the full. Let me know.
If you want, we can move on to the next presenter and come back to you if that's easier.
Let me see if I can. I'm going to have to share it, so I don't want to hold people up. Hang on a minute.
Okay, no problem.
Share screen, okay. I can't share it. You've disabled me.
Okay, hold on one second. Let's see, Shannon, do I have the ability to give her the sharing rights or?
Yes, so you're gonna move to her name.
Okay.
Go to more.
Yep.
And then make co-host.
Sorry, everybody, that shouldn't have happened.
Okay, all right, Deborah, you are now a co-host.
Okay, let's see.
You should be able to share.
Okay. Okay. Let me know when you can see my screen. Can you see my screen?
Yes, we can see it.
Let me check. Sorry, wrong one. Are you okay? Can you still see the PowerPoint?
We can see it.
Okay, great. Okay, I'll start now. Apologies, everybody. Okay, so I'm presenting this project on behalf of the eQual Consortium, of which we have a number of people have joined the call today, and they're listed in the poster authors. So we know that in observational research, rule-based algorithms are one way to identify phenotypes of interest. However, whilst validation of a phenotype using clinical adjudication of a patient's health record is often desirable, generally we only ever see part of the elements of performance of that definition, such as the PPV. In terms of COVID-19, we are aware that cases can be identified based on a variety of different definitions, such as using a PCR test, an LFT test, or even symptoms. And in March 2020, an emergency ICD-10 code was issued to be used when coding the disease. At the initiative of the EMA, the ECOR network, which I'm representing today, was created with the aim to conduct multi-center cohort studies on the use of medicines to treat patients with COVID-19. And a proof of concept study is currently being conducted using this network based on a common data model, and this is available with the NCEP register for those who are interested. One of the objectives is to explore the performance of different coding definitions for COVID-19. And for this proof of concept study, we created 4 definitions as shown here in figure 1, the most sensitive being based on the ICD-10 code I've just mentioned, plus also positive PCR lab test result where available. And these definitions go through to a definition based on symptoms alone. So there are 4 definitions. Our current strategy, which is a very exciting one, is to use the pHeValuator, which is a tool developed within the Odyssey community for validating phenotypes without the need for clinical adjudication. And this is particularly important where studies use databases where permission to view medical records is very difficult to obtain. On the right-hand side, I present the main steps of the pHeValuator methodology. And these are basically to create a prediction model to predict diagnosis, in this case, COVID. And this uses data from cohorts from the data sources created that reflect definite cases, probable cases, and also non-cases. This prediction model is developed using an automated variable selection lasso method, using all the patient available information. Next, one applies the prediction model coefficients to all individuals in what's called an evaluation cohort to calculate the probability of having COVID based on covariates. And this I think I've got a little bit more time. I can't hear you. This evaluation cohort is a random selection of observations from the database, which is broader than the study population. And finally, for each definition, one creates a 2x2 confusion matrix of true positives, true negatives, false positives, and false negatives. And using this information, one can calculate the diagnostic accuracy, the sensitivity, specificity, positive predictive value, negative predictive value for each of the definitions that you wish to test, using the evaluation cohort values as the gold standard. For those of you interested in more, the guidance is available in the GitHub library for generic detail. And here I've just presented an adaptation of that as currently being applied to our database. Importantly, the pHeValuator was updated to version 2, including an option to specify a time period before or after the index date within which to limit symptoms, which is likely to improve sensitivity. And therefore, accordingly today, we decided not to present our interim results to you as based on version 1 because they do not reflect progress in the development of the tool. So I hope you will bear with me and we will present those at a later time. I'll pause there and thank you and happy to take any questions.
No question from the chat yet.
Stunned into silence. Apologies everybody for the slight technical hitch, and I'll stop sharing now.
So I have a question. So this seems a very interesting method, right? Leveraging the tool in Odyssey library. So what is the next step after you're developing this methodology, and what would be your next step?
So we haven't developed the methodology per se. We've adapted the tool that was available already from the Odyssey community. So we're very grateful, and we're working heavily with the experts that have actually developed the program to help us try and refine it so that we can explore whether it can be used indeed to improve and identify the various COVID-19 definitions. You know, obviously, you know, we don't want misclassification of patients. So, you know, we want to make sure that, you know, a true case is a case, particularly when you can't actually go and do any manual adjudication. So we think this is very important. So we are working on this and hopefully we'll be completing the results for publication soon in the next couple of months.
Look forward to seeing it. Thank you.
So do we.
All right, thank you, Deborah.
No worries.
Good job. Okay, I'm going to pull up the next one. Okay, great. So our next presenter is Miriam Hempenius from University of Utrecht, and will present on exposure misclassification in pharmacoepidemiology, sources, and relative impact.
Thank you. Yeah, there is my poster.
There you go.
When you conduct a pharmacoepidemiological study, there is always a risk of exposure misclassification. For example, when you think that someone uses the drug, but he does not, because he's non-adherent to the prescription. Or you think someone does not use the drug, but he uses it without this being captured in your study database, for example, with OTC use. And this is depicted in figure 1 on the left on the poster. So knowing that exposure misclassification exists, how bad is this? What is the impact of exposure misclassification on your effect estimates? And what if the misclassification is differential or differs between two drugs? We looked for answers in this simulation study. And therefore we constructed 2x2 tables based on the true exposure status and moved subjects either downwards for misclassification due to non-adherence or upwards for uncaptured exposures, and calculated the observed relative risks. And we used literature-based values of exposure misclassification for all scenarios. And maybe you can now scroll downwards to the poster. Yeah, okay. We started with looking at non-differential misclassification. Using different values for non-adherence and uncaptured data, we found that in general, the impact of non-adherence was larger than the impact of uncaptured exposures. And you can see this in table 1. For example, 25% non-adherence caused about 20% bias on a log scale versus 5 to 10% bias for 25% uncaptured exposures. Secondly, we looked at differential misclassification by introducing 2 subgroups. For example, men and women, with different risks on the outcome and different proportions of misclassified exposures. We assumed that the exposure had no relation with the outcome, and we wanted to know how large the differences in misclassification needed to be in order to observe clinically relevant deviation from the null effect. And these results are shown in the figures on the bottom of the poster. We found that these differences needed to be large. Take, for example, a risk factor that doubles the outcome risk. To observe a relative risk of 1.1 instead of 1.0, you would need 10% versus 49% uncaptured exposures for those with or without a risk factor. So that were huge differences. We found the same result when we applied this to a comparative effectiveness setting, in which we compared 2 drugs with each other. When drug A had 20% non-adherence and drug B 36, one could observe a relative risk of 1.1 for drug A versus drug B instead of 1.0. So again, there were large differences in the extent of misclassification needed between the 2 drugs. So yes, exposure misclassification has an impact on your effect estimates, especially misclassification due to non-adherence. The impact of differential misclassification or differences between 2 drugs was, however, limited. And how large the impact is depends on the specific study. And I recommend testing the impact as a sensitivity analysis. And this manuscript will be published in PDS very soon. And we provided a lot of tables and figures in the manuscript and the supplementary materials that you can use for that aims. Thank you, and I'm happy to take any questions. No questions so far.
There's a note congratulating you. Fantastic work.
Thank you.
From Judith.
Yes, no questions. So, okay, thank you, Miriam. Okay. Our next presenter is Benjamin Bates, who is a postdoctoral fellow in cancer pharmacoepidemiology at Rutgers Robert Wood Johnson Medical School, and he will be presenting validity of ICD-10 heart failure administrative codes among the elderly in the United States. And give me 1 second, Benjamin, to pull up your presentation. There you go.
Okay, so essentially what I'm going to do is, as I speak, I'll kind of go through the typical format of the background objectives, methods, and then over to the results and conclusion. So our study looked at the validity of ICD-10 heart failure codes in the US. Essentially, the background is that individuals with heart failure are at increased risk to having poor outcomes, and these types of patients are often assessed using Medicare data, specifically ICD-10 codes, which presently have not been validated for acute heart failure hospitalizations. So our objective was to assess the accuracy of the first or the second position ICD-10 heart failure diagnosis among patients in Medicare. So we used a data source of 50% random sample of Medicare patients with parts A, B, and D. And through a sampling method, we obtained 200 charts of essentially from hospitals of patients with heart failure across the United States. And you can see the population kind of inclusion exclusion criteria and then the sampling method. And then if you scroll down, just to bring up about the validation method. So we designed a heart failure abstraction form, taking into account the medical history, medications, physical exam, and then created gold standards as well to assess for acute heart failure hospitalization. And then we had cardiology trained physicians. They abstracted the information from the medical records and adjudicated the heart failure status of whether it's acute heart failure or not, based on our gold standards. And then for our analysis, we assessed the types of comorbidities and characteristics of these patients, and then calculated the positive predictive value of 95th percentile. So in table 1, just to point out some key points about this is a Medicare population. So in general, it's an older population with an average age of 80 in our sample. And the table essentially breaks down between first or second position of this 200 sample. And then the first claim position had 62 individuals and the second claim position 138. And so just to break down some of the characteristics of these patients in the hospital is that the first position claim were more likely to meet acute heart failure hospitalization of a criteria, which was 85% versus 71%. These individuals are more likely to have an echocardiogram performed during the hospitalization, all signs which represent that it's potentially acute heart failure from a clinical standpoint. And then in table 2, we assessed a positive predictive value for the first position or second position. And in this, you can see that the first position had a positive predictive value of 90 to 98% of being acute heart failure, whereas the second position ranged from 47% to 66% based on the gold standard. Then if you attempted to combine first or second claim position, your positive predictive value ranged from 59 to 76%. So the conclusion of our study is that the first position ICD-10 heart failure does accurately capture acute heart failure hospitalization, whereas the second position does not. And researchers need to be considerate of if you attempt to combine the first and second claim that you lose positive predictive value. And that is all I have, and look forward to any questions.
I have one question, Benjamin. Just looking at table 1, I see a difference between gender. So the first claim position, that's about 63% female versus second claim position, which is about 54%. Is that kind of in line with what you'd expect for this particular, for heart failure, this disease?
That is an interesting point, because both essentially these are individuals who either the first claim essentially is the heart failure in that first position versus second position potentially indicates that a history of heart failure. And so maybe this is more hypothesizing here, but for a second position claim of meaning a history of heart failure, maybe that skews a little bit more towards male, at least going from less predominant female to a little bit more, nearing that 50 percentile there.
Thank you.
So there's a question, if it's fine if I read it out there.
Yep, go ahead.
The question was there any difference by type of heart failure for HFrEF versus HFpEF? And that actually, so essentially our validation, we have 2 general studies of validation, and one was assessing the acute heart failure hospitalization, which I'm presenting on here. And then for the HFrEF and HFpEF validation, that's going to be presented at AHA in November.
Thank you. I don't see any additional questions, so thanks, Benjamin.
Of course. Thank you, guys.
Okay. All right. Our next presenter is Judith Riera Arnau from Hospital Vall d'Hebron, and she will present a cookbook for estimating treatment duration from databases of routinely collected electronic health data participating in multi-source studies. And Judith, I'm going to pull up your presentation right now.
Perfect. Are you able to hear me properly?
We can hear you fine. Yes.
Perfect.
Sorry. Okay.
Perfect. So I'm Judith, and I'm going to provide you with some information on our cookbook project for treatment duration estimation. As background, we can see that when conducting cross-national drug utilization studies, there's missing data to estimate in an homogeneous and confident way a treatment duration. In addition, the information required to calculate the number of days of treatment of individual prescriptions or dispensings is often incompletely recorded and may vary across different data sources substantially. All these raise concerns over the way that exposure is defined and reported in pharmacoepidemiologic studies using electronic health data, and may question its generalizability and combination possibilities. So our first aim was to identify standard terms and variables needed to calculate the number of days a person is receiving a treatment, and to define a series of calculation options so flexible enough to adapt to different data settings with an heterogeneous availability of prescription, dispensing, and product information. We did all this through review of European guidelines and expert knowledge of databases and considering different dose forms. Okay, so if we move on to table 1, as our first result, here you have listed and defined some of the terms compiled to constitute a common data model to describe medicines and products. It should be kept in mind that not all these variables are mandatory to perform a calculation, but they are considered here as we intended to be flexible enough to adapt to each database casuistry we may be dealing with. We have many more listed, but here there's a shot of only some. A second result in table 2, here we are 3 examples of the recipes created using different variables. These are illustrated for an acetretin medicinal product. For example, the first recipe includes the number of units within a box and the prescribed units to be taken daily. And the second one includes the amount performed daily dosage. Daily dosage can be assessed through the well-known defined daily doses, DDDs, prescribed daily doses, PDDs, or simply the cadency this is registered in the database. The third one includes the total amount per medicinal product, which might be useful for pods of solutions or creams, for example. As you can appreciate in the last column, each option leads to slightly different outputs. So this will have a repercussion when calculating exposure when we read articles and we want to make comparisons assessing safety, effectiveness, or adherence. Thereby, my conclusions are that richer vocabularies are needed to capture information to define exposure across data sources, and additional tools are needed to incorporate the nuances between component information in calculations of exposure in multi-data source studies especially. As future steps we raised from this project, in the work frame of an international project on retinoids use, these calculations are expected to be applied and automatized through our studio function. And so far my presentation, but let me lastly acknowledge all the contributions of my colleagues. And if there are any questions, I'll be happy to answer. Otherwise, in the top of the poster, you have my email and LinkedIn contact. Thank you.
Thank you, Judith.
You're welcome. Everything's absolutely clear.
Oh, here we go. I think there's one.
There's one question.
Okay, so the question is, what about when a patient is hospitalized?
Okay, this will depend strongly on what is captured in the database that want to apply this kind of calculations. But we raised recipes thinking about also intravenous, intraarterial drug forms. So it's expected to, if this information is available in the data registry, it can be used to calculate duration through the recipes we are raising. We also expect to refine all these calculations to include, for example, properly the concentrations of certain products and other products that don't have a specific unit of presentation. For example, tablets, pills are very clear, are pods of creams or pods of solutions, which may be administered intravenously in a hospitalization. It's a little bit difficult, but we are improving this. So my answer is that if it's registered in the database, it will be included in our recipes. Thank you. Also, you may notice that for some variables, a specific unit of as milligrams, grams, and whatever are considered. So previous to these recipes, we are checking a step that checks the units that are registered in the database for each variable.
Okay, thank you. I don't see any other questions in the chat window.
Thank you, perfect.
Okay. And okay, last but not least, we have Heather Danish from RTI, who will present validation of acute outcomes among patients with type 2 diabetes in the Clinical Practice Research Data Link, CPRD. And give me 1 second, Heather, to pull it up. Okay, there you go.
Okay, thank you. Let me just move something over here. Alrighty, thank you everyone. And again, my name is Heather Danish, and on behalf of me and my co-authors, I am presenting our poster on the validation of acute outcomes in the Clinical Practice Research Data Link, or CPRD. CPRD is a primary care electronic health records database in the United Kingdom and the UK. And this validation assessment was conducted as part of a post-authorization safety study. So to give you some context. In this study, we assessed the positive predictive values, or the PPVs, of diagnosed coded algorithms in CPRD to identify patients who are hospitalized for acute kidney injury, we abbreviate it as HAKI, hospitalization for acute liver injury, or HALI, or a severe complication of urinary tract infection, which we refer to as the SUTI outcome. The study population included individuals registered in a general medical practice in the UK. They were aged at least 18 years and were initiating a glucose lowering drug from November 2012 to December 2018. In figure 1, it presents the pre-specified algorithms that were used to identify cases for each of the study outcomes. We used READ codes or ICD-10 codes in the CPRD Gold database and the linked Hospital Episode Statistics, or HES database. Figure 2 outlines the process used to validate cases for each of the study outcomes. An adjudication committee with 3 clinical reviewers used information from electronic patient profiles, and when available, they also used questionnaires completed by the general practitioner, also abbreviated as the GP. And along with clinical case definitions that are also outlined in Table 1. And they used all of these pieces of information to classify each case as either a confirmed case, a confirmed non-case, or a provisional case. The provisional cases were those that did not have sufficient information in the patient profile and or the GP questionnaire to either confirm as a case or confirm as a non-case. Okay, I think you can scroll down a little bit. So in Table 2, and go down a little bit more, it's quite long. Table 2 shows the disposition of reviewed patient profiles, the receipt and review of completed GP questionnaires, and the adjudicated cases. And Table 3 shows the PPVs for each of the 3 outcomes. So among all HAKI cases that were included in the adjudication review, approximately 32% were confirmed as actual HAKI cases. So this is the estimate labeled as PPV1 in Table 3. The estimate labeled as PPV2 does not include the provisional cases. So in other words, we only included those with a definitive case status in this PPV calculation. So only those that were either confirmed as a case or a non-case. Among all the HAKI cases that had a definitive case status, approximately 63% were confirmed as cases. For the HALI outcome, hospitalization of acute liver injury, the PPV1 estimate was 33% and the PPV2 was 56%. And for the severe complications of urinary tract infection outcome, the PPV1 estimate was 15%, quite low, and the PPV2 was 48%. So in summary, the algorithms that we use for identifying these acute outcomes in CPRD, they resulted in moderate PPVs after we excluded the provisional cases from the PPV calculation. So thank you, and I'm happy to take any questions.
Okay, I'm not seeing any questions popping up in the chat window.
Okay, thank you.
So thank you. Thank you, Heather.
Mm-hmm.
Okay, well, thanks everyone. That concludes the session. I want to thank all of the presenters. I want to thank my co-moderator, Xiaofeng, and thank all the participants. Just a reminder that the session has been recorded and all of the presentations will be available after the meeting is over. And at some point, hopefully in the next few days, the winner will be announced as well. So thanks, everyone. Have a good
Thank
good
you,
day.
Vinny.
Thank you.
Thank you. Bye.
Thank you very much. Bye.